Welcome to Medicine Handy Point. Today our topic is to discuss the history taking in case of dyspepsia. So let's first define dyspepsia. Dyspepsia is actually a medical term, actually a condition which actually refers to discomfort or pain in the upper abdomen after eating or drinking. So it's basically upper GI tract problem and it's related mostly to the food intakes. So it can present with pain, discomfort, and a variety of symptoms like bloating, heartburn, blushing, nausea, abdominal pain, feeling uncomfortably full, loss of appetite, and barfing. So a variety of symptoms and mostly related to upper GI tract. So now the question is that what could be the condition we should be looking for in case of dyspepsia. So first, if the patient comes with upper abdominal pain, so we ask about the onset, we ask about the duration, we ask about the nature of the pain, where it burning, spasmodic, stabbing, sharp. Then we ask about the radiation, severity, and then we ask about the relationship to the food, which will tell us about the aggravating and relieving stuff. So first, we systemically, if we start from esophagus, condition like GERD, gastroesophageal reflux disease can present with dyspepsia. So ask question relating to that. Ask about retrosternal pain, which is aggravated by bending forward. Ask about how many pillow you put under the head at a time of sleeping, timing of food intake at night, nocturnal symptoms. Do the pain wake you up at the night? Is the pain and the pain? This pain is increased particularly by calcium channel blocker, nitrates, and theophylline. So ask about blood pressure. Ask about any heart problem. Ask about any respiratory problem, asthma, COPD, yeah, and are they taking theophylline or not? Not. Ask about bisphosphonate use. If they are having osteomalacia and they're taking bisphosphonate, it can cause esophagitis. So it will present with sternal burning pain. Next is ask about gastritis and gastric ulcer. So nausea and vomiting. If the stomach is unhappy, there will be nausea and vomiting. So ask about nausea and vomiting. Gastritis and gastric ulcer pain is aggravated by food intake. So ask about that. Ask about history of NSAID, steroids use, and smoking. All associated with gastritis and gastric ulcer. Now next, ask about duodenitis and duodenal ulcer. Ask about is the pain is relieved by the food intake. Ask about previous H. pylori infection. Ask about do you have any bug detected previously in your stomach. Then ask about pancreatitis. Ask about radiation to the back. History of gallstone, alcohol use, steroids can cause pancreatitis. Ask about thiazide diuretic use, antiviral, and azathioprine are the main drugs causing steroids. Sometimes furosemide can also cause pancreatitis. Ask about belly pain. Ask especially if you have a right upper quadrant pain which is relieved by food, which is worsened by food intake and radiates to right shoulder. So that will point toward gallstone, cholecystitis. Ask about IBS, in irritable bowel syndrome. Ask about lower abdominal pain which is relieved by defecation. So if it is the case, maybe the patient is having the dyspepsia because of the IBS. Now, in the end, ask about gastric malignancy. In gastric malignancy, the patient will have early satiety, will have weight loss, night sweats, and lymph node enlargement, especially in the neck. So, ask about that. Next, ask about the warning symptoms, because if the warning symptoms are there, so there is something sinister going on. So ask especially about anemia, hematemesis, melena, weight loss, persistent vomiting and dysphagia. These are indication for actually for urgent endoscopy. Cardiac condition like heart failure also present with epigastric discomfort. So ask about chest pain, orthopnea, and PND. Diabetes causes gastroparesis, and the patient will present with dyspepsia. So ask about the diabetes as well. I hope you like the video. Please subscribe to the channel. Thank you.